morning, everybody. Today I will be talking about a case of uveal effusion syndrome and how it was a diagnostic dilemma for us. So this case highlights the diagnostic complexities and management challenges that are inherent with uveal effusion syndrome. We had a 42-year-old male who presented to us with bilateral visual loss. It initially started with the left eye, later involved the right eye, and this was a 1 year duration history. There was no history of flashes, floaters, use of thick glasses, any use of sulfa or antipsychotic drugs. The patient was a hypertensive, he was on thiazides. There was no family history of similar complaints. On review of the medical records, the patient had visited a hospital recently where his documented vision was 6.6 in the right eye, 6.18 in the left eye. There was a documentation of choroidal effusion. He was started on tablet Visolone 40 mg from that hospital, and he was on every 5 days taper. The MRI report that he carried with him showed a choroidal detachment and suprachoroidal effusion in the left lobe, and his blood parameters showed a CRP positive report. When he presented to us, he had a visual acuity of 612 best corrected and 618 in the left eye. The IOP was 18 and 20. The anterior segment findings showed prominent episcleral vessels in both the eyes. The AC depth was Van Herrick's grade 2. Otherwise, there were no other positive findings in the anterior segment. The posterior segment findings, the fundus image showed a media clarity of grade 1. The optic disc was normal in size, shape, color and margins, and there was diffuse pigmentary changes which was seen at the posterior pole and the periphery. Also, there was exudative retinal detachment that was seen at the periphery. The corresponding autofluorescence image showed hyperfluorescent and hypofluorescent lesions, which looked like the leopard skin fundus, and the angiography showed exudative retinal detachment. So we thought it was a thiazide induced choroidal effusion. We discontinued the thiazide with physician consultation and started the patient on telmisartan. Also, in view of the choroidal detachment and the exudative RD, we started the patient on propranolol and eplerenone. Unfortunately, the patient was lost to follow-up, but when he returned, he said that he was very compliant on the treatment that was given to him. We observed a limited response to the treatment. He presented 3 months later. The visual acuity was 636 in both the eyes. The new development was that the exudative detachment had increased and there was a posterior subcapsular cataract which had developed. So as you can see, the exudative detachment has increased. There is a posterior subcapsular cataract shadow also that can be seen, and the autofluorescence, now the leopard skin fundus looks more prominent. There was a choroidal detachment and an exudative RD in the USG-B scan. So we considered the differentials for exudative RD, and we investigated the patient for inflammatory chorioretinopathy, posterior scleritis, choroidal tumors and masquerades. The PET scan was normal for the patient. The MRI was within normal limits, and the blood parameters also, the CRP had settled. The other parameters were also within normal limits. The treatment challenges were that the patient was lost to follow-up, there was further deterioration, and the steroid trial initially when the patient came from the outer center did not work. So we considered a surgical intervention. The patient underwent the scleral window procedure. This is about 4 days back only the patient has undergone a scleral window procedure, and we are observing him for resolution right now. But our observation during the surgery was that the sclera was very thick. It was more than 2 mm thickness, and we sent for the histopathology. The report was collected telephonically, which showed the abnormal collagen deposition. So to conclude, uveal effusion syndrome is a complex disease. It is the diagnosis of exclusion, and we need to exclude the other causes of exudative RD. So early recognition, thorough evaluation, is very important to rule out the other causes. Discontinuation of medical, any contributing medicine should be discontinued. And however, the response is varied, and surgical considerations such as scleral window procedure uh, should be considered for potential visual rehabilitation. Thank you.
What was the axial length? Like, did you
So the
rule out nanophthalm or
it wasn't an anophthalmic eye, sir. We also did a UBM for the patient. Already due to the paucity of time, I could not include all the details, but the axial length was normal.
Normal.
Yes, sir. It was most likely a uveal effusion type
Idiopathic.
3. Type 3.
Okay. Thanks.